Okay. Okay, Google Chrome is using your microphone. That's fine. Can you hear me? It looks like you can.
Yeah, we can hear you.
Right. I guess I'm going to have to take my headset and bury it. Okay, beg pardon with everybody. Let me just get this kind of back over here again. Share application and screen. Application window, fluoroscopy. All right. Okay. It's like I said, I wanted to apologize for interrupting you guys earlier. And I mean, I came in there sort of thinking I was going to set, there's a little bit of chaos at my house right now. Well, it's quieter now, but I came in here just setting everything up and you were all there. And I thought, oh my God, I have been making you all wait. So I do apologize for that. So this is a kind of an overview of the whole process behind fluoroscopy, some of the equipment, some of the radiation protection. In some respects, guys, utilizing this along with the materials that we talked about, and if we go through this next week, and some of the materials that we talked about yesterday, they're all kind of integrated. And so you'll find that some of what we talked about yesterday would be useful with regards to this and vice versa. So just kind of for my sake here, just running down memory lane, unlike you, when we did fluoroscopy, and I'm going to have to tell you, this was way before me. We weren't wearing goggles, but we did it, generally speaking, in the dark because to get the best brightness that we possibly could, we had to have a dark background. Now, you don't have this problem. You can have the lights on, you know, maybe not all the ways up bright, but you don't have an awful lot of difficulties with actually viewing a fluoroscopy monitor. We did. And prior to when I was in the business, the physicians, the radiologists, actually had to sit in a darkened room wearing red goggles for about 30 minutes because what they were doing was light adaptation. It was pretty silly if you can get down to it. This is kind of a picture now. We've got the lights on here, obviously, but this was really, if you get right down to it, kind of the way that we're doing something, for example, like a barium swallow. You will notice that the device that the physician has in front of him is just sort of a flat panel. All they had was a screen. The radiation came through the table, through the patient, through the screen, and the radiologist was sitting right there. So, of course, it was coming right at him, too. And the like. If you look on top of his head, he actually had his red goggles there. He's also, as you can see, wearing an apron and gloves. So they were somewhat aware of what the problems were. The real thing here was that the brightness of these screens was so poor. Like I said, you had to be virtually in blackness to actually go to work and do anything. And as you can imagine, there was a few safety issues involved with something like this. All right, here's another picture that's showing you something essentially the same thing. Again, the X-ray tube is under the table, the radiation goes through the patient, and the physician is looking directly down onto the screen. And the screen really glowed, but it didn't glow particularly well. So how did things actually change? Well, it was the advent of what was called an image intensifier, which quite honestly is just an amplifier. And what it would essentially do was to take the poor light that was actually emitted from the system, from the phosphor, and amplify it. Okay, it would increase essentially the brightness of the system. And that, of course, meant that we didn't have to work in places that were pitch black dark. The radiologist didn't have to sit in a darkened room, all of those different things. So obviously, leaving aside even something as simple as the safety issues involved, including, by the way, radiation issues, you can kind of imagine, um, people kind of adapted to this pretty quickly. Okay, now the other thing that happened was, is you probably noticed from the way they were looking at that screen and everything, they're putting their face right in front of the screen, the radiation's going through. They were able to attach a camera to the image intensifier and then basically through wires and stuff, broadcast it onto a television screen or a monitor, if you would like. The lovely thing about that, of course, is that you had the ability then to actually capture the whole image. We used to use VCR tapes, believe it or not, and basically record fluoroscopy. So this is kind of the way it works, kinda, okay? Please understand, technology is always changing, and this is changing too, and we're going to talk about this as we go along here. And as I told you, most of the time, not all, but most of the time, the X-ray tube for fluoroscopy is located underneath the table. So whether the patient is standing up or is basically supine, the X-ray tube, if our patient is in this position, is coming in through the posterior side and exiting out the anterior side. The radiation is going to, of course, be attenuated by the patient, and the radiation that does come through actually will hit the image intensifier. I remember what I said, the image intensifier is going to increase the brightness. There's a phosphor in there. Again, we're going to go over all of this. It'll amplify that brightness, and that in turn will be picked up by a television camera. They keep putting TV here all the time. It's a camera. And that camera in turn will take the brightness, convert it into an electronic image that's going to be sent over to a monitor. Okay, so that's kind of the way this thing whole works. So from a kind of a supine point of view, and I hope you don't do your patients when they're fully dressed, okay, you would expect with this system, you're going to have it's remarkably like what you would expect on a radiographic machine, in the sense that, yes, you have an X-ray tube, the filtration, we talked about this a little bit yesterday, you expect to have similar filtration, understanding that the voltages, the kilovoltages used here are generally higher. You do have the ability to control the field size. Right? There can be a grid present there. You can actually move it or, bring it in or push it back. The image intensifier, and then finally the video camera that we were just talking about. So this is not that far off from what y'all are used to seeing, assuming you've seen too many machines. This would be something that might have been used, for example, in a special procedures room. I have to confess, if you look over there to the right, you see the boxes of what says EZM. That's contrast media. You can kind of see there, we've kind of piled and stored stuff everywhere we could actually find anything. With this type of a table, this table had the ability to basically turn up so that the person would be standing upright. Okay, couple of things there. Down there to the, I guess it's the right, there is the footstool, so when you stood somebody up. In addition, as I told you, the X-ray tube is underneath. Radiation comes through, and that large kind of a tower thing that you see up on the top side is where the image intensifier is located. So when I say an image intensifier, as I said, I'm talking about an amplifier. What we're trying to do is to basically set up for a real-time image that refreshes enough that you can actually see it without a lot of blur, and is bright enough so that you can actually basically do these procedures in what's essentially would be normal room light. I mean, you might lower it down a little bit. This is kind of the central premise behind this, and you're probably looking at this going, oh my God, it's not that big. Now remember, this is an intensifier, okay? So notice we're talking about one single X-ray. That X-ray is going to hit what's called an input phosphor. Now, a phosphor is something that causes light to be emitted. That's all you need to know. Radiation hits the input phosphor, cesium iodide, okay, and causes the emission of light. And you can see here on the top side where it says 1,000 light photons. That is going to actually, those photons are actually going to hit the photocathode, which is directly on the input phosphor. Okay, cathodes make electrons to electrons, and that's essentially what happens. The electrons are pushed across the image intensifier tube, and in turn are going to strike another substance, but it's also a phosphor. Okay? The electrons stimulate the phosphor to emit light, because that's what phosphors do. That light is picked up by the camera, assuming that's what we're using. So this is just another representation of precisely the same thing that I just talked about. Okay, you can see over there to the left where the X-rays are coming in. The input phosphor is the kind of pinkish device that is directly adhering to the photocathode, which is the orange device. So you're going from X-rays to light, from light to electrons. The electrons are pushed across. You notice there's an anode there. What do anodes do? Okay, the electrons are pushed across, strike the output phosphor, and that in turn causes the emission of light. Now, the substances used for the input phosphor and the output phosphor, just so you know, are different. Okay, the input phosphor is stimulated by the presence of X-rays. The output phosphor is stimulated by the presence of electrons. So you're talking about completely different, substances. You will have to learn the input phosphor, that's cesium iodide. You don't have to worry about the output phosphor. Okay, so now we have this device, and again, next semester we will be going into it in a fair bit of detail, but we have this image intensifier that has produced greater amounts of light. It's an amplifier. That light is emitted, and it's going to be picked up by some kind of device that can pick up that light and produce an electronic image. We got a couple of different ways we can go with this here, okay? Old time machines will use what's called a Vitacon tube, and this is just a camera tube. Remember with the big video recorders that people had, that, big things that they would hold onto their shoulders because they were so big, and all? That's the type of tube we're talking about. It literally was a tube, okay? That tube would take the light and ultimately was going to produce an electrical current based on the information that the light provided, okay? We don't do that much anymore, but that was pretty common. Literally, that tube was simply attached to the input phosphor, or it was kind of adjacent to it, and the light coming off the output phosphor was adjusted. Basically what I'm talking about is they use mirrors and lenses to pick up the light in a different way. So this would be the kind of thing that you might expect to see, again, with a fairly new fluoroscopy system. Again, the X-ray tube is underneath the table. You can kind of see we got a table on here with a mat. That's nice. Okay, this whole device that's extending across is the image intensifier, and plus the control panels. It is attached to the X-ray tube. So if you move this device up towards the head or down towards the feet, the X-ray tube goes with it and remains centered. You don't ever have to worry about that. Now, the radiation goes through. Where I have the II, that's designated image intensifier. So that's where that device is there. And it's like I said, it's a large tube. Okay, that in turn is attached to the TV camera. I added the word camera in there, okay, because that's going to take the light, convert it into an electronic signal that's actually going to end up with the monitor. Okay, now, that's what we did a lot, and I suspect you probably, if you go out there, you probably find a machine or two that still uses something like a Vitacon tube. Modern machines today actually don't use a camera any more than you using a camera per se in your phone. What they do is a digital camera, which is basically just a transistor, okay, a thin film transistor. There's two different kinds that we're going to talk about real briefly here. Okay? But really, if you think about it, that's pretty doggone tiny. Now, why did they go over to this? Well, there's a couple of reasons. This is, for one thing, the resolution was sure to got a lot better. The other thing was that they could take multiple images and less radiation. So there's a lot of good points behind this. When we talk about digital fluoroscopy, This is usually what we're talking about, okay? I don't know that I would say, and I'll explain this a little bit later, but, that the system itself overall is digital, but the camera is digital. That used to, I'm quite honest with you, that used to confuse me because they kept insisting that it was a digital system, and I'm looking at this image intensifier. It don't look digital to me. Um, what they were using, like I said, though, was what's called a CCD or a charge coupled device or a CMOS, okay, which is complementary metal oxide semiconductors. Look, these are two sensors. They are basically transistors. They use different technologies of which you do not have to go to work and learn. Just understand that they are both available to be used as digital cameras. That's really about it. Okay. So just be familiar with them in that respect. Okay. Now, if you think about it, incidentally, when we think in terms of cameras on the phones and stuff like that, most of us think of CCDs because they started out being the better of the two processes. That changed over time, and just basically from kind of poking around and investigating, CMOS has improved enough that it can stay on its own. Now, if you are interested in further information in terms of the technology of these two devices, I did go to work and put a link there. It does a pretty nice job of comparing the two of them. Okay, just remember they are the the transistors that are used in digital cameras. Okay, so as I said, most of what we call digital fluoroscopy just uses a digital camera. The process of actually amplifying or acquiring the image and amplifying it um, isn't isn't digital. Anything that's using that image intensifier isn't digital. Okay. If we were using a flat panel detector system, like you do with DR, that's digital. But that's kind of like I said, that's the way that people kind of talk about it, and it's not highly accurate. All right. So this is the kind of, I guess you would say, if you count using an image intensifier, this would be sort of the process in that respect. So you have the fluoroscopy tube that's way over there, as you can see there to the left. And as we move from left to right, the radiation is coming through. Now they're calling it primary radiation because that's from the tube to the patient. Okay. Some of the radiation, of course, as you know, is attenuated depending on, if there's barium in there or whatever. Okay, the transmitted or X-ray radiation is emitted from the patient. That was what was going to strike the image intensifier, and specifically the input phosphor of the image intensifier. Okay, now that energy gets amplified, and what happens, as you can see there, it's going to go through something called ABC. We're going to spend more time with this basically tomorrow. Okay, but what this is automatic brightness control. And this is a feedback loop mechanism to monitor the amount of brightness that's given off by the intensifier and constantly adjusting it so it stays bright enough so we like it. So, for example, if you went over something like the lungs, and there was a lot of radiation coming out, it would damp down the amount of radiation so you don't basically get something that's too bright. Same thing if you go over a part, let's say, for example, it had a whole lot of barium in it and all the radiation was being attenuated, and it would boost it up there so that you could see enough of it so it's bright enough to be acceptable. So it's a monitor of that, or you can call it a feedback loop mechanism. So that automatic brightness control is going to be controlling the amount of brightness in turn that's going to hit the CCD. Okay, and the CCD, remember, is charge coupled device. That sort of takes the place, in a sense, of our camera. Now, the next thing here is, I don't know if we've talked about this one, ADC. They love their abbreviations. All this simply means is this is an analog to digital converter. Now, this is assuming that you actually need something like this, but this would take an electronic signal and digitize it. I mean, it's sort of self-explanatory. And by the way, there are such things as digital to analog converters too. Eventually, of course, all of that stuff is going to go on to your TV, and this time it's the real TV, the TV monitor. Okay, now, are there true digital systems out there? Yes, right? There are not lots of them. They are expensive, but they are kind of, I guess you would say, kind of picking up over time. You know, you may even write, excuse me, I take that back. There actually are some out there in the Atlanta area. Ms. Hibbert, I don't know if you remember, I don't know if you're even there, but when we went over to that international radiography clinical site, that they actually had a flat panel detector fluoroscopy system. So, but like I said, they are pretty doggone expensive. Now, why do they have advantages? Yeah. Okay. Well, one thing is you don't have this big old tube hanging over. So you have a much smaller size, and that obviously is helpful. Okay. Like any flat panel detector, you have the same advantages as you do with this digital radiography, one of which is a much extended grayscale or dynamic range. Okay. It is also set up so that you don't run into some of the spatial distortion issues that you do run into with an image intensifier. And what we have found is that it has greater stability. I find that one kind of interesting because of the whole fluctuation issues sometimes with these transistors. But that's what they made the statement, so I'm just reporting. But the nice thing too is that there's no camera, okay? Think about what that does in terms of your resolution. The information is going to go from the flat panel detector fluoroscopy screen directly to the monitor, okay? This is the same thing as with you guys with DR, okay? It goes directly from the flat panel detector to the monitor. Okay. One of the nice things about something like that is that you're not constantly converting it into different modes, if you'd like, of energy. So that also in turn helps to improve resolution. Okay. So this is what a true digital fluoroscopic system would look like. Obviously, the table is the same. I mean, you can see there's a bucky, there's a footstool. If you look up on the top side, you still have the kind of a C device because the X-ray tube is underneath and it's still attached to the stem back there. And you still have the control panel top side there. And that's basically where you're going to have buttons for controlling, whether the X-rays are on or off, whether you're going to move that machine basically up towards the head or down, different magnification modes, different things like that. But there's no big old thing on the top. And that's because you have a flat panel detector here and no image intensifier tube. Okay, so here's just another one. And this one actually can show you a little better that the X-ray tube is essentially right underneath. All right, now, one of the things I was talking about yesterday was the distance basically between the source to skin. And I looked it up. Basically, when you're talking about a fixed unit, okay, a fixed unit has a minimum SSD of 38. Oh, I put inches there. It's 38 centimeters. I beg your pardon. Okay, or 15 inches. Okay, if it is a mobile system, it is 30 centimeters or 12 inches. I just wanted to make sure I got that because I put it on one PowerPoint, it said 36, another one said 38. Now, this is a nice one here also for showing you, I guess you say in a sense, the construction of a fluoroscopy unit. Okay, this is kind of what we call a C-arm in the sense that you see there's a C, so that the X-ray tube is on one end, okay, the fluoroscopy unit is on the other end, and essentially the thing stays fixed. That's why things just, the tube does not ever, it's not off center, okay, or at least it shouldn't be. On this particular device, as you can kind of see here, it just sort of slides up and down this whole unit. I suspect they probably use something like that with interventional. All right, this, on the other hand, is a true mobile system, or what we call really a C-arm. And with the C-arm, okay, starting basically from left to right, you have the base that you can kind of see there that has the control panel. You see there is a button there for fluoroing. There are handles there basically for maneuvering this machine. They are very clumsy, let me warn you, okay? These machines can be moved forward, back, side to side. You can take that C-arm part there. You can identify, for example, on the bottom, there is the X-ray tube, and it has a covering over it to ensure that we keep that minimum SSD. And you can turn that thing left, right, angle it. You can basically bring it into a lateral projection. You can do all sorts of things with it. You just have to be very careful with it because it's big and it's clumsy. Over to the right-hand side, you can see that there is a unit there that has a keyboard and things like that. That's where you input patient data and the like. And as you can see, there are a double set of monitors there that is what's used basically for the fluoroscopy monitor. Okay, you have the device, the ability essentially to freeze these things and to save images and the like. There are usually like video discs set up with it so that people can go back afterwards and back and review things. All that stuff is in there. Okay, so that's kind of in general the I guess you say kind of a quickie overview. So you have basically fixed systems. You also have mobile systems. Okay, as a general rule, these with both systems, and like I said, notice I say general rule. All right, the tube is going to be underneath the table, okay, and the image intensifier is going to be on top. There are exceptions to those. They are not very popular because of the radiation dose issues. What are some other things that we can do with these? Well, the one thing certainly is we want to go to work and practice good radiation protection. So it's useful to use that image intensifier as a device to basically protect the operator from radiation. So one of the things we tried to do is to get the image intensifier as close to the patient as we can. Um, Obviously, if they have a needle sticking out of their back or something like that, you have to be careful with all of this. But we want to bring it as close as we can because that helps to stop some of the scatter radiation. The device itself actually attenuates it. Okay. The big advantage also for this is that if you bring the receptor closer to the part of interest, you're going to have a reduction in magnification. Okay. And remember now from going back from check your chart, reducing magnification should improve your resolution. So utilizing the SID divided by SOD as a way to magnify your image for some reason is not very advantageous because there's a loss of resolution. It's not to say that it cannot be done. Now, if you take a look at the images here, what we really have for all intents and purposes is a consistent distance between the tube versus the receptor, but we've adjusted the position of the patient. Okay, so you can kind of see there, for example, in position 1, because of the position, the patient is closer to the image intensifier, the magnification is set up, as you can see there is 1.25. As you bring the patient closer and closer to the X-ray tube, which is on the undersurface, the magnification actually increases. The other thing you might notice is that actually the dose goes up too. So good practice is to keep the patient as close to the receptor as we can. All right, this is another device. This is a fixed system, might be used in a cardiology type system. Mostly I'm thinking that because it does have that kind of curved table. That table can go up and down. Notice that it's on a lever. So what we would want to do is to bring it up as close again to the image intensifier on top where it says Philips and not with the X-ray tube, which is on the bottom there. Okay, so you can use the geometric principles that you already know to magnify an image in fluoroscopy. That certainly is doable, okay? But there's another way of doing this, and I would liken this closer to being what we would call zooming in a sense. Or if you would like, when you basically open things up in your phone by kind of pinching it and opening it greater to make it magnified, it's closer to being something like that because what you're doing is you're reducing the field of view in a sense, okay? But you're not necessarily losing resolution. So this is basically how this kind of works. If you take a look at the one on the top side, there's a 9-inch field of view. So the input phosphor will take 9 inches worth of basically an X-ray field. All right. Now, when it comes over to the output phosphor, that's consistent. So we would say more or less it'd be from 9:1 type of a ratio. If you reduce that field of view, okay, to 6 inches, well, obviously you're not going to get the same amount of information, but what's coming out at the other side, you might notice, is every bit, it's the same size, okay, but it's large, it's the same field size, but the part, like that arrow, is going to be larger. Okay, so what happens is that there's a series of buttons on the control panel in a fluoroscopy system where they can adjust what they call the field of view. So they could go, for example, from a 9-inch to a 6-inch, maybe even to a maybe 4-inch. And in doing that, it basically zooms the image out. Okay. Why would you do that? Well, if you're trying to look at small parts, if you're trying to look at small blood vessels, anything like that, that's the best way to handle it. Because remember now, it doesn't harm your resolution. And if you look at the little things, you kind of need a resolution. The one downside from this is that because we're using a solar field, the brightness that ultimately be coming off the image intensifier will be somewhat less, which will necessitate a boost in the amount of radiation over that 6-inch field of view than you would otherwise get at the 9-inch field of view. Recall, the automatic brightness control, the ABC, is monitoring the amount of brightness. If you have less radiation because of the 6-inch field of view, it won't be as bright and the machine will boost it. So you don't routinely keep these things on small fields of view because of the increased radiation dose. Okay, now there are other ways of looking at this, one of which is how we actually operate these things. Originally, fluoroscopy was continuous. And by continuous, I mean is you push your foot on the pedal, or you push the button, it fluoroed and fluoroed and fluoroed and fluoroed, it never stopped, okay, until you put your finger off of it, all right? It was continuous, in other words, okay? Since there was never any breaks in the fluoro, that certainly would provide you with the highest possible dose of any way of doing this. Now, there are legal limits to the amount that can actually be kind of basically, exposed. You notice it says 10 Rankine per minute. And boy, it's a fair bit. Okay, this is one of the reasons why people go fluoro for hours on end. What is used mostly today are pulsed fluoroscopy, sometimes called intermittent fluoroscopy. And what happens is that rather than having a continuous mode of radiation, beep, what's happening is beep, 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 beep. So the radiation stops in between. When you do something like that, it's sort of like animation. Okay, animation consists of a whole series of static images that are put together, run through, and our brain basically takes that and sees motion. All right, that's what they're doing here. So, for example, you could have 30 pulses per second, and you'd have it on, then off, on, then off, on, then off. And the advantage, again, I repeat, is a reduction in the radiation dose. Now, I've given you an example there of 30 pulses. You can actually make them lower than that. So it could be, for example, at 15 pulses, or it could be, for example, at 7.5. Understand, though, when you have less, okay, it's like really bad animation where everything is just jumpy, okay? But there's some things that probably be just fine with. I mean, why do you have to have perfect animation, if you'd like, or perfect motion, if you're looking at a barium swallow, for example? You could use a much lower frame with that, reduce the radiation dose. So what we typically use today is the pulsed or intermittent mode. I've used the term frame. I think your textbook uses the term pulses. What we're basically talking about is a burst of radiation, then it stops. Burst of radiation, then it stopped. Okay, and that can be changed depending on what it is you're actually doing. So the picture here kind of gives you a little idea. You can see under the kind of the purple there. Um, continuous exposure means it's just radiating, radiating, radiating. On the other hand, with the pulsed exposure, there's considerably less amount of radiation. And like I said, our brains kind of take over and see motion anyway. It sort of translates. Okay, now what's another thing that is very, very useful in this whole continuum? We've gone from continuous radiation to pulsed radiation. We also have what's called last frame hold. What this does is it leaves the last live image up there on the monitor. Okay, so you fluoro, it goes beep, beep, beep. You take your foot off, that last image freezes on the monitor. Sometimes that's all you need. Let's say, for example, if you were in the middle of a procedure and they were trying to insert a nail in something, they insert the nail and all they basically want is one quick picture to check to see if the nail is gone fully through like it's supposed to, if it's positioned properly. That's all you need. You don't have to sit there and hold the fluoroscopy down while they sit there and try to figure out whether or not they've got it in properly, okay, or anything like that. Obviously, okay, this is seriously going to reduce the radiation dose. Now, on those monitors, you might remember the first picture I showed you had two. You can take that last image and then essentially kind of cross it over to the other monitor. Basically, what I mean is you save it. So that's also very, very useful because it's useful basically because people can go back and review their work. All right, I think we mentioned this yesterday, which was high-level control fluoroscopy. Now, normal fluoroscopy has a legal limit of 10 Rankins per minute, which I said, which is high enough. There are situations where they have to actually boost it. And, the two real reasons are going to be if you have somebody that's very obese and you're trying to actually get through to demonstrate something. The other thing is that, if you give more radiation, you're going to have, a better signal to noise ratio. You may remember that, which means you're going to get better resolution. And if you are trying to cannulate small vessels, let's say, for example, if you were doing an embolization of a uterine artery, if you're trying to evaluate whether or not they have all been embolized, you need to have that resolution to look at those small vessels. So both of these situations are possible times when a high-level fluoroscopy can be useful. But remember now, what's happening is that you have increased the amount of radiation per minute, as you can see there, a whole lot. And that basically has to be very carefully used. Okay, now, surgery. The reason I'm sort of folding surgery in here a little bit because like 99% of what you do in surgery, quite honest, well, maybe 90%, is going to be with fluoroscopy. We do some static projection radiography in there, but for the most part, it's usually going to be fluoro cases. So it doesn't look really, really attractive, but this is basically where everybody kind of starts because you obviously have to wash your hands. That has never changed, really, if you get right down to it. And what we're going to do is to take a look at the whole overall system and how basically C-arms actually going to get integrated into all of this. So what you have here is, in a sense, a kind of a setup where we've got the monitor positioned in a specific place, and you can see the surgeon and maybe the assistant surgeon are there reviewing the materials located on the monitor. The device there that has the plastic on it is the image intensifier. That plastic is sterile, as is all of the paper that you see there, the blue paper. Okay, because we have that hanging so close over what essentially is a sterile field, okay, they have to keep all of that sterile. And that's just basically one more thing that you have to be constantly aware of, which is really what you can actually touch and what you can't. All right, so there you go. There is our kind of device, this C-arm. It still is clumsy as ever. You can also see that you have a monitor device there with a recorder. And as you can see there, the dual monitor system. Okay, here's another one. All right, now I've just pulled this. This is a fixed system. Yes, ma'am?
Miss Kendall,
Yeah.
can you kind of tell or show us what things you can touch a little bit and what things you can't?
Oh, yeah. Okay, fair enough. I'm going to have to bail out of here to basically, because I don't think you can't see my arrow, can you? Of
Yes.
course,
We can.
you can see it?
I think we can't see it on the PowerPoint, but we can see it on the
Oh,
on the
obviously.
so
Okay. I'm pointing to
anything.
the patient's head right now. You can see that.
Yeah.
So we're done. All right. Okay. Now, the basic rule was something like this. Let me see if I've got this. Okay. It's actually a little further along, but I'll address it right now. Okay. When you're looking at something, for example, from this perspective now, the surgeon, assistant surgeon, somebody who's the surgical tech, they are gowned up and their front from the waist up and the arms are essentially considered sterile. The back part is not, below the waist is not. The masks, the hats, none of that stuff is sterile. Okay, so it's just the front side. And basically, between the two of them there, they have to be careful because they don't want to basically have one back side facing the other's front side. Everything that's in blue here right now, let me rephrase that. From approximately the table up is the sterile fields. The stuff down in here is not sterile, although we do try very, very hard to kind of avoid hitting it as best we can. Okay, you can see where the surgical instruments are. That's basically a fully sterile tray right there. Now, where the tube is concerned, you're looking at the image intensifier tube, and it has a large plastic bag on it. That is sterile. What we basically do with that is that the surgical tech or somebody is going to take that bag, put it over the image intensifier. We kind of put our hands inside and essentially pull it back down and then fasten it in place. And the fastening in place is sort of a combination between the tech and the surgical tech, trying to get that thing kind of placed in. We keep our hands on the inside, which would not be sterile, in an effort to ensure that the outside stays sterile. Now I'll go back over this again. All right, so there we go. With something like this, now you notice they're not even wearing hats or anything. So this is probably an interventional procedure rather than a full-blown procedure, surgical procedure. And the reason for that is when they do things, for example, like arteriography, they're going to make a small hole in the groin, and that's it. While they have everything kind of draped as they do here, that patient is awake, probably a little bit stoned, but awake, excuse me. And basically, they keep that whole area sterile, but the only real area of concern, the worked area, is actually down in the groin. Okay, now the gowns are still the same thing. The front is sterile, the arms waist up. Notice that there's somebody in the background. She has on a hat, which they frankly should, and she has an apron on. I should mention that the surgeons, or in this case, the interventional radiologist, will have an apron on underneath their gown. So as you can imagine, it's not real pleasant. Okay, now, I just wanted to show you that some of this stuff is not what you call very elegant. This is actually how a hip can be done. What they are doing here, this is actually in surgery. They're going to be doing a hip reduction and probably a pinning, I assume, with the left hip. They have them in this device because what they're going to do, okay, let me back this up. When you break a bone, especially in thigh, the muscles spasm and they will pull the bones, they will compress them. They'll keep them out of place. Okay. What they do is they put the patient out so the patient doesn't feel anything. And what they're going to do is to kind of basically adjust the bones so that the bones are back in appropriate alignment. Okay. So they've got this patient in this device here. It looks terrible, doesn't it? Here. And that's exactly what they're going to be doing here is they're going to pull the leg out a little bit and reduce the fracture. Now, at the same time they're doing this, they have to be very, very careful. This is the image intensifier right here. There's the X-ray tube. And remember that we still have that 12 inches here. What they're trying to do is to watch what they're doing while they're actually doing that reduction. Okay, notice that the other leg is completely out of the way. That's what they'll do. Now, once they get this, when they have this in place, we'll pull the tube out. They'll get the patient ready for surgery, and then we kind of go back at it again. Okay, don't worry, you'll see them. Hip fractures are as common as popcorn. All right, now, you saw the way that thing was set up. I tried to spend some time basically talking about, radiation protection and all. Here's some of the things, and look, there's as many different here than it is anywhere else. Time, distance, and shielding, okay? You don't have a whole lot of control over the amount of fluoro time they choose. That's basically going to be dependent on the physicians and the procedure you're doing. If it's really easy procedure, you might be out of there basically with 5 minutes of fluoro. If it turns out to be a really, really hard, and trust me, sometimes they're trying to put bones together, for example, and it's almost like, what do they call it, Jenga? Something like that, where you pull those little blocks out, and everything falls apart, and then they have to go back in there and try again. It can be that difficult. Okay, shielding. Now, they don't have shielding in the walls in surgery and things like that, but you are expected to wear a shield. And a wraparound shield is what people typically wear so that you are not basically kind of limited to only facing forward. Okay, on the other hand, a wraparound shield is heavier. Not everybody likes that very much. For you, distance is probably the most important thing if you are in surgery. It's not like you are there to assist the patient or frankly anybody else. What you're really there for is adjusting the machine, okay, and making sure that it's working properly. Okay, that does not mean that sometimes you have to get in there a little bit closer, but for the most part, that's not necessary. So you can usually take that step back. That is always the best thing to actually take. Okay, this gives you a little bit of idea. Now, this is a fixed system. Okay, if you have a protective curtain in front of them, which you do for almost anything except when they're doing something like a myelogram, okay, you can kind of see where the distribution of the radiation is kind of out there. Your best bet, obviously, is to be sitting pretty much over it, standing over it here, behind the radiologist, okay? The good thing about being behind the radiologist is you're right there if somebody needs you. The radiologist knows that you're right there, but you're also getting the maximum amount of protection. Take a look at what the kind of the distribution is here versus the one that you have over here to the right. Okay, when there is no fluoroscopy, when there is no aprons and stuff like that for drapes, okay, you can see how the amount of radiation basically is much higher. Now, the other thing I want you to notice is that this is the area where somebody would be standing. Okay, if this was up even higher, that would even be more intense. And that's, again, one of the reasons why they try to keep that image intensifier down. Okay, so what would be some practices that would be best practices? As I told you before, they try to keep the image intensifier as close to the part of interest as they can. Understanding that you can't always do this. Again, if you are doing a lumbar puncture on somebody and there is a needle hanging out of their back, you can't keep that tube too close. That's kind of terrible. But for the most part, if you're doing an upper GI or anything like that, try to keep the eye as close as you can. Okay. If you look over here, this one is kind of a dumb picture, but it was the best I could actually come up with. The best practices is the X-ray tube is underneath, okay, and the image intensifier is on top. A big part of the reason for that, you can almost see right here, which is you're using the eye to help attenuate the radiation from striking the chest, thyroid, and eyes. That's always the better way of actually going. All right, so some kind of basic rules. I've actually kind of already mentioned these things. It'd probably be best to wear wraparound aprons, but regardless, if you're not, face whatever the unit is, where the radiation source is. So if you are near there and you have to step away, you have to back up. Don't just turn around. I can't tell you how many times I see people in surgery that sort of forget that they're not, protected on the backside because they're wearing a regular apron, and they just basically go hither and thither and on. It's sort of like, why are they even bothering? You want to stay out of that general area. Okay. When you're talking about doing an upper GI, like I said, best place to be is behind the radiologist so the radiologist knows that you are right there. Okay. Otherwise, don't stand near the patient too terribly much. Okay. Now, there are going to be situations where you have to assist the patient. I mean, please remember that's the reason why you're there. You should not be behind the control panel. Okay. If the patient needs help with the barium cup, if the patient needs their pillow fluff, well, maybe not quite that, but how about if they need help basically turning over on those hard tables, any of those things? That's what you're there for. All right. Remember too, you don't need to go to work, and if you're standing there behind the radiologist, put your hands inside the apron or behind your back. There's no reason to radiate them if they're not doing anything. Okay. Other things here is that when you take your apron off, hang it up. There will be places there for you to hang it up, like we have in our area. Okay. Don't just throw them down because they do crack. And if they crack, then you have the problem basically of leakage radiation. Okay. So I think I've kind of already kind of pointed all of this stuff there. Sometimes you're going to have to be out there. And if you're not comfortable with that, then go to fluoro. All right, so kind of basically getting back to the surgical team here. This is generally speaking the group, okay? You got a surgeon, you might have an assistant surgeon. You're going to have a scrub nurse, or it might be a surgical technologist. It could be either. You're going to have an anesthesiologist or anesthetist, somebody, okay? There's a circulating nurse, and like I said, might be a surgical tech. The surgeon, okay, the scrub nurse / surgical technologist will be gowned up, okay? The anesthesiologist is not gowned up. And by gowned up, I mean basically sterile gowns. Okay? Everybody has lead aprons on, right? The circulating nurse is doing just that. She is the one that basically is going to be going outside the room, answering the phone, kind of you name it, they do it. If they need additional equipment, she's the one that's going to go get it. So that's the way that more or less works. You don't wear, yes?
Is it your job to make sure they have the protective wear on, or is it they do it? And do they do it over the gowns or under the gown?
It has to be underneath the gown. That's a very, very interesting question. Okay. When I first started, I did not presuppose to tell anybody what to do. As I got older and quite frankly crankier, okay, I turned into a terror. And I used to get mad because the young surgeons would only wear the skirt and not wear the top. And I'd yell at them. Okay. But since I was older than almost all of them, I tended to get away with it. And sometimes it actually made a difference. Now, the anesthesia, I usually took an apron and just put the apron on the chair that's up there by the head of the patient. That was just a courtesy. So kind of made sure with them. You have to assume that they have, lead aprons on underneath their gowns, okay? Because you can't see. They put that stuff on before they go in there and get basically do scrub or get gowned and gloved and all of that. So you're not going to know. You just have to assume. Like I said, you kind of have to know your people as to whether or not you can get away with basically terrorizing them a little bit. Like I said, as I got older, I got much crankier. When they didn't go to work and have their full apron on, I used to get very mad. If they kept turning around when they were not supposed to, I used to get very mad. I could get away with it then that I never could get away with it when I was 25. Okay, that's kind of the way. You're not going to know. because you can't see underneath the gowns. I mean, you don't see the surgeons, okay? There is usually a large collection of aprons floating around surgery somewhere. If the surgeons, if they're going to need one, they're going to have to go find one. Like I said, we usually take care of the anesthetist or the anesthesiologist. You don't dress and you don't get scrubbed out, but you do have to dress out. Now, different hospitals have different rules. So, for example, some places require you to wear booties. Um, Others say you don't have to. Some people say every time you leave surgery, you have to change your scrubs. Other places say you can just put on a lab coat or something like that. Again, you just follow the policies of the place that you're actually at. Okay, you will have to wear a mask. You will have to wear a what do you call it, a bonnet, um, those type of things. Okay, but they'll you know they'll let you know when you're actually in surgery and stuff like that, where you go to change and all of that stuff. Certainly, if you're in surgery, you probably could wear street clothes walking in there and then just get changed out in the what do you call it, in the dressing area. Okay, now this is what you were kind of asking before, which is the kind of like, what do you touch or what do you not touch? Okay, as I said, you guys are not going to be in sterile gear, but you are kind of responsible to help maintain that everything stays sterile. Um, you're also working with a piece of large equipment that is as clumsy as all get out. When you get into surgery, I really encourage you to try to practice managing that C-arm before you actually get into a procedure. It just, if nothing else, you appreciate just how clumsy those things can actually be. Here's kind of the rules, okay? If it has paper on it, it's sterile, okay? Don't touch it. So the everything is disposable. So the gowns, for example, they may or may not be. I mean, some of them they're going to basically do them, but the trays, okay, the drapes that they put on people. I mean, there's going to be some cloth towels and things like that, but for the most part, if it has a paper sheet on it, don't touch it. Okay. The monitor is not sterile. Okay. Usually, the image intensifier, which will be, if you put a plastic covering over it. Now, in and of itself, it is not sterile. Okay, the X-ray tube is usually underneath the table. That's not sterile. In fact, sometimes that gets pretty messy. But generally speaking, if it has plastic or if it has paper on it, don't touch it. Now, what do you do if you do touch something accidentally? Remember, if you don't say something about it, because I know you don't want to get into trouble, if you don't say something about it, you're risking contamination and that patient can get an infection. And so nobody will love you, I promise this, but do the responsible thing and report if you do contaminate something. Just don't do it very much. So you can kind of see on the picture here, okay, they're probably just doing a lumbar type of puncture. So they have the patient, and this is obviously in surgery, okay, they have the patient basically kind of draped in a sense. They do have the darker blue towels on there. Those are cotton. I love that apron that's basically on her. It's half hanging off. Kind of ditto with the guy. He's got it sterile on the top side there because it's hanging right over the surgical area. That would be sterile. The base of it lower down would be not. That's where you kind of more or less handle it. These have buttons so that you can angle them and things like that as well. So just kind of keep that in mind. Okay, so there you go right there. The areas there that are green are sterile. Okay, that's the way that kind of works. Now, the person that's over here all the way here, that's the like circulating nurse or something like that. Okay? When they open these things up, okay, remember now, the inside is sterile, but the outside of a pack is not. So it's the person who is sterile will put a hand in there and bring it out. Okay, so that kind of give you a little idea. So the mask is not sterile. Okay, the shoes are not sterile. Okay, it's just the green areas. Okay, so in terms of this whole thing of maintaining a sterile field, and I'm about to stop talking here, I promise. Okay, you're only going to, if you are helping them, and sometimes like at night, you might be doing this. Okay, place only the sterile items within the sterile field. So if they ask you to basically open something up, okay, you have to basically maintain the rules for sterility. Okay, and we can get a chance perhaps to practice some of this stuff again next semester or the following semester. Okay, be careful, don't reach over a sterile field or anything like that. Okay, and when it says don't allow unsterile persons to do that, that's includes you. Okay, make sure the area stays sterile, and if it's not, report it. Okay, if anything is damaged, wet especially, it's considered contaminated, and they need to go to work and remove that and fix it. And if there's any question, okay, then they really need to break it down and reestablish the sterile field again. Okay, all right. So I noticed that it's 11 o'clock. Actually, it's after 11 and my mouth runneth over. Do you have any questions? We'll finish the rest of this up. I guess that's Wednesday. Dead silence. Okay. I guess I'll turn off the recording.